Al Prasad Eye Institute, Hyderabad, and also in Will Eyes Hospital in Philadelphia, and observership in Chile Eye Institute in San Diego. The position and credential is she was a vice president and now is the secretary of Asia Pacific Ocular Oncology Pathology and member scientific committee of All Indian Ophthalmological Society, section edition, Indian Journal of Ophthalmology, and leadership and development program of APAO. And also she has a lot of awards and honors. Rastrisha Gaurav Award in 2021, Woman Power List in 2021, Top 100 Women Ophthalmology Worldwide. And in the American Academy of Ophthalmology, the Achievement Award was the best paper in 2015, 2014, 2011, the best poster award in 2021, 2017, and 2016, and the best show video award in 2013. Asia Pacific Academic Ophthalmology Achievement Award in 2017, All Indian Ophthalmology Society Best Paper Award in 2015, Oculoplastic Association of India Best Paper and Best Video in 2011. Well, but all of these things are important, but she loved teaching. Yesterday, she told me this is the most important thing, I think so. Thank you for staying here. We are so proud to have you here. And well, now we listen to you. Thank you. I can listen to you.
Thank you so much, Dr. Germán, for this kind invitation. Hola, buenos días. Gracias por invitarme. Am I right? I tried. Thank you very much for the kind introduction. In fact, it's my honor and my pleasure to be here and giving me this opportunity and platform to connect to another end of the world. And I'm sure this Zoom platform and online platform has been, a way of connecting with everyone in any part of the world. And I'm so happy and I consider it so fortunate to be able to connect this intellectual bunch from Argentina. And I wish and hope I can visit you guys very, very soon. So as Dr. Bianchi said, that I'm going to take you through ocular surface tumors, and probably there is a reason that we chose this particular topic, because I deal with cancers from any part, of the eye, from the eyelid to the conjunctiva, to the intraocular, to the orbit. But I think majority being anterior segment consultants, anterior segment specialists, refractive surgeons. I think this is on a broader perspective going to be very, very useful for majority of you. And that is why we chose this. So when I asked Dr. Germán, like, how much time do I have to present? He told me 45 minutes. 45 minutes is a long, long time. And I told him that I would love to speak for 45 minutes because I'm so passionate about the subject and I can speak for hours, a whole day regarding the same. But I don't want you to get bored in this long lecture. So I'll try to keep it a little bit interesting with few cases, scenarios and stuff. And I wish it was interactive so that we could have interacted, but I'm sure it's not possible in online. So these are my affiliation. I'm from Bangalore, India, and this is my major part of the work. I'm also associated with a hospital in Dubai and Sharjah. So when we talk about anterior segment lesions or ocular surface tumors, there is a very broad classification. It's easy to classify depending upon the color. We have amelanocytic, which can be reddish, which can be yellowish, which can be pinkish or orangish, that is amelanocytic. Then we have the melanocytic. Melanocytic lesions are those which is brown in color, which contains melanin pigment. And we see it very, very commonly. And then there is yet another category that we call it as mixed, where it can be melanocytic or amelanocytic. Another broader classification. So I'm going to take you through amelanocytic first, and then we'll switch over to melanocytic. A kind of a brief overview of all these lesions and the most important lesions. Now, whenever we talk about tumors or lesions, first and foremost, it is so important as a specialist or a general ophthalmologist, basically to differentiate between benign lesions, inflammatory lesions, and from the malignant lesions, because malignant lesions of ocular surface can be dismal for a patient as far as eye salvage is concerned, vision salvage is concerned, and sometimes can even lead to death. So the amelanocytic benign lesions, we all know it's very common. It can be papilloma, actinic keratosis, hyperplasia, keratotic plaque, oncocytoma, dacryoadenoma, and there is a list of it, which can be even congenital or even acquired. Then we have the malignant variety of squamous cell carcinoma, lymphoma, melanoma, liposarcoma, etc., etc. The main objective of my talk today, I would actually stick on to certain clinical diagnosis, the differentiating features, and management of these lesions. Now, when we talk about benign versus malignant, we all know that starting from the history, the clinical symptoms, the clinical signs, we will be able to differentiate these lesions. So in your left, you see the benign lesions. Okay, now what is striking in your right, where you find these malignant lesions, is that it's more fiery red. And the most striking feature is the feeder vessel in all these things. And this is the most characteristic clinical feature that as an ocular oncologist that I look for in order to differentiate a malignant lesion from a benign lesion. Now, there are various other things that we look into. Of course, the age of onset, how it is progressed. If it's a rapid progression, we all know that it's a bad tumor, right? The location, the mobility, the fixity, how deep it has invaded, all these things helps us to differentiate between particular lesions. Now, this is a 72-year-old gentleman with a gradually progressive mass since 1 year. And as you can see here, it is amelanocytic. There is no melanin. It's not pigmented at all. It's kind of translucent. So in transillumination positivity test that we usually do for cystic lesions, this seems to be positive. And this is nothing but actually an inclusion cyst of the conjunctiva, which was in fact referred to me because it was a large cyst occupying the whole of the inferior fornix to rule out a neoplasia. So it's not a neoplasia. It's a very clear-cut, very easy case of an inclusion cyst, which of course was excised. And the reason for this inclusion cyst was that the patient has undergone multiple surgeries of conjunctiva in the past, and that is where the inclusion cyst can be common. This is a 30-year-old lady with eyelid swelling. As you can see here, she has some kind of fullness in the right eye, upper lid, lower lid, and also in the lower lid of the left eye. And she says that this has been there as a child and gradually it has been growing. Now, I kind of inspect it and evaluate it closely. And this is what I see. All right. So there is this fleshy mass in the superior conjunctiva involving the fornix, inferior, also the lateral fornix, and also a similar kind of a lesion in the inferior conjunctiva involving the fornix of the left eye. Now, this is very, very typical of a dermolipoma. Why is it called dermolipoma? I'm not sure whether it's very clear. There is a hair follicle which is arising from here. There is a dermal component over there, and lipoma because it's filled with fat. lipoma. So it's yellow in color. So a childhood history in a patient with some kind of a lesion like this, the most common is dermolipoma. Dermolipoma is usually solitary. We find it in the supratemporal aspect of the globe. But as in this case, rarely they can have multiple dermolipoma also involving the inferior conjunctival fornices. So what we did was to excise it. I went ahead excising the upper lesion, the lower lesion, and also the other eye. And this is how she looks after the excision biopsy. Now, this child, she was 16 years of age, and there is a fullness in the eye over here, and this is what she has. It's more of a lipomatous component than the dermal, but this is again presenting from the childhood. This is also a case of dermolipoma, and this is how we excise, and this is after the treatment. Now, this is 69-year-old gentleman. He was referred for a mass in the conjunctival mass in the left eye. And well, the referral doctor said that it is kind of a recent onset. Could it be something, a lymphoma or any neoplasia? And that was the reason that he was referred to me. So, well, he already had a CT scan with him where the referral doctor was very, very worried for this lesion which was seen in the eye. And well, it shows some kind of, homogeneous lesion in the CT scan where you can see it is almost in the color of the fat and continuous with the orbital fat over here. And on elevating the eyelid, you can see both the eyes has this fat which is popping out. It's a simple diagnosis. Now, when it is present in the childhood, it is dermolipoma. But when it is present in an adult where there is a fat, it's a simple fat prolapse. So this is an orbital fat prolapse in both the eyes. Now, orbital fat prolapse is pretty common, and it's usually due to the weakening of the Tenon's capsule associated with aging. It is also seen commonly with weightlifters, squash players, where they have, exerted too much of, pressure all along their life, where the fat can prolapse into the conjunctival cul-de-sac, and it's more common in males. Now, what do we do? This is similarly how we do the dermolipoma also. It's done under local anesthesia, where we kind of, push the fornices and the orbit to make it more prominent. It's a local anesthesia, tenon, subtenons anesthesia, which is given over here. The tenon space is opened after the incision over the conjunctiva. A very, very small incision is made, I would say a micro incision. And then, the fat is prolapsed out. We don't pull the fat too much because there is a chance of, too much of hemorrhage and retrobulbar hemorrhage. So you have to tweak it very, very, very gently, like step by step. And then by partitioning the fat globules, we kind of, again, pull it very gently outside. And what I am very particular is about, in order to avoid any bleeding, retrobulbar hemorrhage, is to put an artery forceps so that there is hemostasis of the large vessels, which is feeding these fat and the surface, and then cut it out. Yeah, so this is how, it's a similar way that we do dermolipoma also. But when you do a dermolipoma, we all know that the palpebral lobe of the lacrimal gland is situated here and the lateral rectus is situated here. The two things that we have to really, really take care is the palpebral lobe of the lacrimal gland to avoid injury to that, spare it. Lateral rectus muscle, never go towards it, and preserve the surface as much as possible. So this is immediately after the surgery with some amount of subconjunctival hemorrhage. And well, this is actually 3 weeks after the surgery where the entire thing is, resolved. Now, this is a very interesting case. In fact, she was referred as question, a case of fat prolapse, bilateral lesions. Both eyes, this is the right eye, and similarly in the left eye, she has a lesion here. Well, this didn't look to me as a fat prolapse because it is more thicker, it is more firmer, and it's more diffuse. It's not yellowish as a fat. So what I did was went ahead doing an imaging for her. Now, this is the closer view of the right eye. As you can see here, a very elevated lesion. Now, whenever I see this, large engorged feeder vessels on any of the lesions in the ocular surface, I really get worried. And I know that it's not going right. All right. Now, on the other hand, this eye also, there is this large feeder vessel, and this has some kind of an orangish color. All right. Amelanotic, no pigment, orangish in color, which I would kind of consider as a salmon color. Now, salmon color in the ocular surface is not good. It's not at all good. I went ahead doing an imaging here. So this is a right eye where, of course, it's involving the lateral rectus muscle. All right. In the left eye, she has an involvement of the lateral rectus muscle as well as an inferior rectus muscle. So this is basically a lesion which is involving the extraocular muscles of the eye and which is elevated and seen in the ocular surface. So it's just not ocular surface. There is something deeper that is happening. So you have to evaluate and see which are the cases where there is a suspicion of something which is really hiding behind the globe and jutting out of the ocular surface. And this is some kind of that case. So what I did was I was suspecting a muscle lymphoma in this case. Whenever there is a salmon color, lymphoma is the first differential diagnosis. So what I did was I went ahead, did an incision biopsy of the lateral rectus muscle from the left eye. And when we do an incision biopsy, we don't cut it horizontally. Okay, like we just go along the fibers of the muscles so that we don't injure the muscle, and a very tiny portion of the lesion is very gently incised without injuring the lateral rectus muscle and without causing any functional issue to the patient. So the diagnosis, as expected, came as non-Hodgkin's lymphoma, extramarginal zone, low grade. So this is the most common lymphoma of the ocular adnexia, and extramarginal zone lymphoma, which is a B-cell lymphoma, is the common one. So whenever we have lymphoma of ocular surface, the second thing after proving histopathologically is we do a PET scan, the positron emission tomography scan of the entire body to rule out whether there is any other foci in other part of the body. So in this patient, it was normal. The bone marrow biopsy was done. That was normal. And we staged it. So any cancer is staged, right? So she was stage 1A without any systemic involvement. Now, how to treat it? So whenever we talk about lymphoma of the ocular surface, conventionally, historically, we have always considered radiotherapy as the treatment of choice. Now, the conservative dose or the conventional dose of radiotherapy for ocular surface lymphoma is around 2,400 centigrade. Now, this is an interesting paper that came out by Dr. Bita Ismaili from MD Anderson, where they considered ultra-low dose radiotherapy for the definitive management of ocular surface, ocular adnexal B-cell lymphoma. And since this patient had bilateral lymphoma over the ocular surface, in order to reduce, the side effects and complication of higher dose of radiotherapy, I went ahead doing a ultra-low dose radiotherapy for her with combination of intralesional rituximab. The rituximab as an immunotherapy drug is an anti-CD20 medication. So most of the lymphoma will be CD20 positive. And if it's CD20 positive, rituximab is usually one of the management protocol for these patients, especially as a systemic injection. Now, we have, kind of jumped ahead thinking that we can locally treat this with intralesional injection. So this patient, initially we diagnosed, we staged it with incision biopsy and PET scan. And then the step 2 was to treat her. So I went ahead doing ultra low dose radiotherapy, and that is 200 centigrade first day and 200 centigrade the next day, a total of 400 centigrade compared to 2,400, which is conventionally given. And as you can see here, the entire muscle thickness, everything returned to normal. And she has been doing fine without any recurrence past 7 years. Also with the introduction of injection rituximab into the orbit. Similar case, a salmon-colored lesion over here. clinically suspicious of lymphoma. This involved the lateral rectus muscle in the patient over here. You can see the lesion was sitting on the lateral rectus muscle and also involving the inferior oblique muscle. I excised it. I didn't, give radiotherapy because it was over the muscle and it was not growing into the muscle. And then, of course, the patient also received injection rituximab for the stabilization of the disease. We gave 3 cycles and the patient has been doing good. So this is, my series of treating extraocular muscle lymphoma and ocular surface lymphoma with ultra-low dose radiotherapy and local rituximab injection, which I do in my practice. 56-year-old lady, redness and irritation, right eye, in fact, both eyes since 1 year. And she has been constantly treated with steroids, lubricating eye drops, anti-allergic eye drops by practitioners thinking that this redness will go away. In fact, this is not a redness that will go away. Let me take you through the pictures, okay? This is the closer view of the picture where you can see this lesion. Feeder vessel again, dilated vessels here, both, nasal and temporal bulbar conjunctiva of the right eye and the left eye. And you know what this is? This also has a salmon color. So this was a multifocal bilateral lymphoma in this patient. It was a MALT lymphoma. The only thing that I did was to excise all these lesions, and she's doing stable and she's been fine. So these are the various methods of treating ocular surface lymphoma, and this is the various presentation from a subtle redness to subtle small lesions to large bulbous lesion, even involving the muscle deep down into the orbit. So conjunctival lymphoma is a lymphoproliferative, tumor. It is in a spectrum. It can be reactive lymphoid hyperplasia, and the other end of the spectrum is the lymphoma. So it can have association with systemic lymphoma. 17% of it's unilateral and more if it is bilateral. So the importance of systemic evaluation is so crucial in these patients with lymphoma to rule out any other foci in the body. Because it is said that the systemic metastasis association with conjunctiva is as high as 20%. All right. And the sites of systemic metastasis most common is lymph nodes, abdomen, brain, and lungs. So this is the clinical staging system. I'm not going into the detail. I'm just going to tell you the AJCC-TNM classification that we follow. In conjunctiva and orbit is T1 and T2, and the Ann Arbor classification for the staging, systemic staging. This is a 70-year-old gentleman, whitish lesion, right eye, growing since 4 months. Well, it's very tiny, situated at the limbus, involving the limbus and the conjunctiva. Again, what worries me is these big, large vessels growing over there. Anything with large vessels, not good at all. Now, he has got this nodular lesion, and this is a rose Bengal staining that we have done, which has been taken up over there, and this is the presence of keratin. So any amelanotic lesion of the ocular surface with feeder vessel, presence of keratin is ocular surface squamous neoplasia, and this is ocular surface squamous neoplasia. Ocular surface squamous neoplasia is an umbrella term, and it is involving dysplasia, carcinoma in situ, and squamous cell carcinoma. So it can be anywhere in the spectrum. So we have to diagnose it. Why is it so important? Because this is the most common conjunctival malignancy. Good news is that it's a low-grade malignancy, but we can have aggressive malignancy in immunosuppressed patients like HIV positive, whoever is on immunosuppressants, and even, congenital syndromes and genetic syndromes like xeroderma pigmentosum. It can be aggressive, it can be bilateral, it can be multiple. Now, as I told you, the clinical diagnosis and the characteristic clinical features would involve, as exactly that you see in this image, nodular, lots of keratin over the surface, large feeder vessels, intrinsic vessels over the surface. It can encroach the cornea, and also look for scleral fixity. So scleral fixity is generally done in our clinic with a cotton bud tip. we kind of try to move it. If it's fixed to the sclera, then clinically, well, of course, it's fixed to the sclera. And then we do a UBM or ASOCT to find out whether there is an invasion into the sclera. And always look for regional lymph nodes, because these malignancy can have preauricular lymph nodes, submandibular lymph nodes, anterior cervical and posterior cervical lymph nodes. Now, when we see these cases, we actually clinically document it in a very, very meticulous manner so that we don't miss out on any findings for further management. Mostly OSSN is in the perilimbal location because there is usually it arises at the transition zone. So anything arising at the limbus involving the cornea and the conjunctiva, always think of an OSSN. It could be either dysplasia, carcinoma in situ, or even a squamous cell carcinoma. Now, this is a similar kind of lesion. There are a few vessels over here, but it's far away from the limbus. And in fact, this is proved to be a conjunctival papilloma. So mostly OSSN will involve the limbus because there is a theory of the transition zone, and that is where it arises. And that is the epitome or the central foci of the malignant lesion. Now, there are different morphological types. It can be fully filled with keratin. It can be purely gelatinous. It can look like a papilla, the papillary form. And in, pigmented population like Asians, Africans, it can also be pigmented. But even though it is pigmented, which looks like a nevi or a melanoma, there is some amount of keratin over the surface, which gives away the diagnosis and differentiation. Now, we see lesions which is only related to the cornea, nothing in the conjunctiva. So any lesion which is wavy form and, which has actually a convex edge, which is growing and progressing towards the cornea, which is gelatinous, white in color, always suspect an OSSN. And this is typically in ASOCT how an OSSN looks like, where you'll have a snout, it is like a snout in the epithelium of the limbus and the cornea over here. And this is very, very, very typical of an OSSN of the ocular surface. Now, we see large lesions where, we have to do UBM or ultrasound B scan, even to rule out intraocular extension. Now, there are lesions which is that large and fixed where even you have to do an orbital imaging, like a CT or an MRI, to look for orbital extension. So this is the extensive workup that we do for these ocular surface lesion. Now, going on to the management of OSSN. Now, what is good and new that we have in our hand is the topical chemotherapy. Earlier, the gold standard, and still the gold standard, is surgical excision. But then what we really have in our armamentarium is the topical chemotherapy. Now, this is the different drugs which is available for as topical chemotherapeutic agent or an immunotherapeutic agent is mitomycin C, 5-fluorouracil, and interferon alpha 2B. Now, if you ask me what are my favorites in this, my most favorite would be interferon alpha 2B. I'm not sure whether it's available in Argentina. We have it in India, and my second favorite would be 5-FU. And if you ask me, why do I categorize and why am I partial, or why do I have some favorites and not so favorite? It's only depending upon the ocular toxicity. Now, interferon alpha 2B has the least ocular toxicity. It hardly has any side effects on the ocular surface. But when we inject, if at all I inject the interferon, they can have a flu-like syndrome. 5-FU has few toxicity, but it's not too severe when compared to mitomycin C. So that's why my favorite stays when you compare mitomycin C and 5-FU, I would definitely choose 5-FU topical 1% for ocular surface squamous neoplasia. Now, there is very definitive indications for topical chemotherapy. Not all cases can actually go for topical chemotherapy. Corneal OSSN, I never operate. I don't want to cause any scar on the cornea. I know it's going to go away with topical chemotherapy. I never surgically operate the cornea case. As in this case, I would definitely go for a topical chemotherapy. Small superficial lesions like this, topical chemotherapy, where there is no, extension, invasion, or scleral fixity, definitely topical chemotherapy. Large lesions like this, I would inject, I would put eye drops, and chemo reduce it to maximum and minimize the size so that it is amenable for complete tumor excision, and that is called chemoreduction. Now, such lesions where it's very diffuse, involving the conjunctiva, involving the cornea, definitely topical chemotherapy and injection for me. Immunocompromised patient, usually even after excision, we put them on immunotherapy, topical interferon, in order to prevent recurrence. So these are the definitive indications. Now, these are few examples of topical interferon. This is how the patient presented after 1 month, after 2 months, and this is after 4 months. It's like magical. You know, patients are very surprised. Oh my God, I put an eye drop and it just vanished. So this is case 1. This is after 4 months of injection and topical chemotherapy. Case 2, after 3 months of injection and topical chemotherapy with interferon. Now, this is a corneal OSSN that you saw before, and this is a complete regression after 3 months of only eye drops with topical interferon. Now, this patient, so topical interferon requires cold chain. You need a refrigerator. We do have poor patients in India where they cannot afford a refrigerator in their home. They don't have refrigeration system. So then we often, prefer topical 5-FU in that case. And this is one of those cases. So this is after 2 weeks post-treatment of topical 5-FU. Remember, it's just 2 weeks that it's almost gone away. And this is after 2 months of topical 5-FU. This was a patient where, he was a poor, financially backward condition where he couldn't maintain the cold chain. So what I did was, it was so extensive, I gave intralesional interferon injection and then topical 5-FU as an eye drop. And this is how he responded. So these are actually a blessing and a boon in the management of OSSN with the topical therapy. And there are absolute contraindications. Whenever the diagnosis is doubtful, never go for it, excise it. Scleral fixity, never topical chemotherapy. Suspicious invasion, no. If it's very, very nodular, extensive, don't go for topical chemotherapy. And if you feel the patient is non-compliant, the patient will not be putting the eye drop, they're busy with their work, they're traveling, never go for a topical eye drop. Now, going on to the primary surgical excision, definitely we have advantages. We have a pathological diagnosis, there is a complete cure, limited duration of treatment, because when you do a topical eye drops, the duration can extend somewhere from 3 months to 6 months. Surgery is like 1 at a go, khalas, it's done. Uneventful post-op recovery, and obviously it's cost effective. So it's considered still to be a gold standard. I'm just going to show you a video here how we do the surgery. Most importantly, you have to delineate the margins. And this is a 4 millimeter clear margin from the lesion that we usually take up to the limbus. And then you excise and dissect it. So this patient had a scleral fixity in this area. I'm doing a superficial lamellar sclerectomy here. There is some amount of sclera which is being removed at this point where there is invasion and fixity. Going on to the cornea, absolute alcohol epitheliectomy. Absolute alcohol is applied for 30 seconds, and then we roll the epithelium, keep the basement membrane intact, the Bowman's membrane intact, and then at the limbus, which is mostly adherent, we excise it. Now, after excision with a wide margin of 4 millimeters, the most important thing is application of cryotherapy. If you don't have a cryotherapy, please don't excise OSSN. We do a double freeze thaw cryotherapy. We go 2 times the entire length of the margin. And if required, with a larger excision, we place an amniotic membrane graft and we stick it with the glue. I don't suture it, and this is how the surgery is done. So going on to this step, I would say the most important thing, of course, excision is important, cryotherapy is very important, and actually submitting the lesion to the pathologist with the margins correctly oriented is so very important, because once the pathologist gives you a green flag of all margins negative, the base negative, then I'm 100% convinced that I'm not going to do anything with the patient anymore, and it's just observation. But this is a histopathology of the same patient where we got a base positive. So the margins were negative, but the base was positive. Now, when there is a base positivity, that means there is some amount of tumor cells still in the bed of the sclera, right? you have to treat it. It's not going to go away with topical chemotherapy. Topical chemotherapy doesn't act for invasive cancers. It's only for epithelial, non-invasive cancers. Now, what is the management that we do is we radiate. So you see here is a plaque brachytherapy. So this is a ruthenium plaque, which is kept over the surface for whatever the residual tumor cells came as positive, that was treated with the plaque brachytherapy, and the patient is doing well. Larger lesions, bigger excision. And this is how we submit our specimen to the pathologist, the lesion with the margins, which is currently oriented. And if, you have a suspicious margins, we take margins separately, like superior, lateral, inferior, medial, and then submit it to the pathologist, where he would report whether it's negative or positive. And this is with an AMG over here. And this is after 6 weeks of surgery where it's healing. Now, there are situations where the tumor is so big where it's invaded the anterior segment. You can see hypopyon over here, and this subsequently went for, scleral melt. And so, well, we cannot conserve the eye in this situation. So what we do is an enucleation. In fact, it's called an extended enucleation, where we, take off the tenons and conjunctiva along with the normal conjunctiva of the other part. Orbital extension, what we do is orbital exentration surgically. Well, we can also consider radiotherapy as the other option when the patient is not willing for a surgery, and we prosthetically give them an exentration prosthesis, making them, cosmetically look better after exentration. Now, this is a case with diffuse conjunctival congestion, unilateral. There is loss of lashes, thickening of the lid margin. This is not an OSSN, but this is something more dangerous than an OSSN. This is a sebaceous gland carcinoma, which is the intraepithelial or the pagetoid spread of the ocular surface. And this is very, very dangerous. So what we do in these situations, even if it's a diffuse OSSN, what we do is a map biopsy. And what do we do in a map biopsy is we take 2 into 2 millimeter biopsies from different portion, the bulbar lesions, medial, lateral, superior, inferior, the pharyngeal conjunctiva and the tarsal conjunctiva, every portion inferior and superior, and the caruncle, and then we submit it to the pathologist to see which are the areas positive and which are the areas negative. Now, this is a 69-year-old gentleman with redness and irritation in the right eye, 1 year, and this is the lesion. Well, it looks like a granuloma. It could be an inflammation, but it looks very, very fiery red. So this is again a sebaceous gland carcinoma of the caruncle. Sebaceous gland carcinoma is not only that of the eyelid, it can come over the conjunctiva, it can come in the caruncle as an ocular surface lesion. Large lesions can have extension into the orbit, so it's very important to evaluate the paranasal sinus, the orbit, and the nasolacrimal duct invasion, which is common with caruncular sebaceous gland carcinoma. So radiological evaluation and lymph nodes has to be examined. So that is in short about the melanocytic lesion. Sorry, now we are going on to the melanocytic lesion. I'm sorry, there is an A over here. We talk about benign and then again we go on to the malignant lesions. Now this is melanocytic. There is melanin pigment, a small flat lesion over here. Well, most of the time we ignore it. It could be a congenital conjunctival melanosis. It could be a PAM, which is unilateral. Something which is more darker, elevated, well, we would think it as a nevus. Something which is more darker is very dangerous. So darker, the danger increases in conjunctival melanocytic lesions. This is a patient presenting with this diffuse, flat, pigmentation all over the conjunctiva. What we call is complexion-associated melanosis, which can be present in an Asian who has a brown skin, in an African who has a brown skin. They can also have pigmentation of the ocular surface, and this is called complexion-associated melanosis. Now, this patient, as you see here, has a complexion-associated melanosis, right? It's a brown skin. There is brown pigment over here. Now, let me show you something here. This is the right eye of the patient. Now, this is abnormal. Well, there is a complexion-associated melanosis in the left eye, but this is not complexion-associated melanosis. It's something bigger than that. So whenever you get an asymmetric complexion-associated melanosis, you have to be careful. So what would we do is we would go and do a map biopsy and see whether it's fine, whether there is PAM, and this is actually highly suspicious of melanoma. So what we do is excision biopsy and map biopsy, and this patient came as conjunctival melanoma of the right eye. So any asymmetric, pigmentation of the eye also has to be thought of something which is more of a grave prognosis. This is very, very typical of a nevus, which we commonly see in our clinical practice, which is the cyst over there, variable pigmentation and multiple cysts over the surface. So usually it appears in the bulbar conjunctiva. It is childhood onset, variable pigmentation. 82% can present with cysts, microcysts and macrocysts. They can have feeder vessel. 64% presents with feeder vessel, and they can have intrinsic vessels also, because as the child grows, the conjunctival nevus also grows. Now, there is anterior segment OCT that we can do in order to diagnose conjunctival nevus from conjunctival melanoma to differentiate the presence of cyst in it. This is a lady who presented with this lesion in the right eye and the lesion in the left eye. Let me show you. So this is not really cystic, it's kind of fleshy, and this is really balloonish and cystic. So this is a presentation of bilateral conjunctival nevus in this young lady, and this came out to be a balloon cystic nevus, which is a rare variety of a conjunctival nevus. This is a diffuse pigmentation. Well, I'm not too worried about this pigmentation because it's very, very diffuse and uniformly pigmented. If there is a variable pigmentation, some nodular lesion, something which is very darker, it would have really worried me. And this came out to be a giant balloon cystic nevus of the left eye. This is the only case that I've seen as giant balloon cystic nevus, and it was very, very special. Now, what do we do when we have these flat pigmented lesions? And this is often the question that people ask me when I present on melanocytic lesions, like, do we do something? Do we observe? So, well, what I studied is regarding primary acquired melanosis. It's a benign thing, right? It is usually unilateral, presenting during the middle-aged. It's usually in the bulbar conjunctiva, most commonly. But if it is in the tarsus or the phoneal conjunctiva, I am worried. If it has feeder vessels, I am worried. All right. Now, what I learned from my mentor, Dr. Carol Shields, is that what she does when a patient, walks into the clinic with PAM is that she actually measures the clock hour. And in fact, this is a paper published by Dr. Shields and a group where they evaluated the number of clock hours, and they actually calculated the relative risk of these lesions converting into melanoma. So the larger the clock hours, the risk of these lesions being conjunctival melanoma is much, much higher. So if it's a 1 clock hour lesion, probably I might just observe. But if it's larger clock hours, I might excise. And anything which is involving abnormally the tarsus, the caruncle, the phonesis has to be taken extra cautious precautions to rule out conjunctival melanoma. Now, the progression of conjunctival melanoma from PAM is whether it is presence of atypia or without atypia, and with severe atypia, the percentage is as high as 32%. So this was a patient with xeroderma pigmentosum that, who was referred to me for this large lesion. He has multiple lesions in, the bulbar conjunctiva, and this is very, very darkly pigmented nodular fixed lesion, which was suspicious of conjunctival melanoma. And he has another darkly pigmented lesion over here. So ultrasound biomicroscopy showed invasion, so I know it's melanoma. So this is how we actually, chart out the entire eye and plan management. So I planned excision of this, and cryotherapy of the other pigmented areas. Now the pigmented areas excision came as conjunctival melanoma, and this is his left eye. So here we excised with a wide margin, and this is how we got it. This lesion was also excised, which also came as conjunctival melanoma, and we did cryotherapy for the other eye, and this is how he looked like. He didn't have recurrence. So we all know that conjunctival melanoma can arise from PAM in 75% of the patients, de novo 20%, pre-existing nevus 5%, and it's so very important. And it's common mostly in Caucasians and less common in our part of the world as far as Asians are concerned. It's elevated, nodular. It need not be melanotic always. It can be amelanotic also. It can be non-pigmented also. There is systemic association like dysplastic nevus syndrome, xeroderma pigmentosum, and neurofibromatosis as far as conjunctival melanoma is concerned. 75% from PAM, 20% de novo, and 5% from conjunctival nevus. So this is a case that I had seen where, this is purely a nevus with microcyst and macrocyst, and this is where it developed into a conjunctival melanoma. So there is a clear demarcation and, evolution of a nevus into the melanoma in this case, which is actually correlating with the anterior segment OCT over here. This is a non-pigmented conjunctival melanoma, but of course, you can see a little bit of trace of pigments over the surface where it indicates that it arose from the PAM that the patient had into a conjunctival melanoma. The rate of regional metastasis in conjunctival melanoma is 40%, as high as 40%, and systemic metastasis as high as 25%, and mortality is as high as 32% in 15 years. So it's so important to identify these lesions and treat it properly. Anything more than 2 millimeters in thickness has a bad prognosis. Anything which is de novo in origin has a bad prognosis. And of course, thickness is the most important thing. We have the TNM staging of conjunctival melanoma. I'm not going into detail of that, but you should be knowing that anything related to the bulbar conjunctiva alone has a better prognosis, which is T1. Anything related to the fornix, the palpebral conjunctiva, and caruncle has a poor prognosis, which is T2, and we have to be careful about it as far as follow-up is concerned. Now, well, anything related to the caruncle, imaging is important to rule out orbital extension. Now, this is kind of a controversial topic, the indication of sentinel lymph node biopsy in conjunctival melanoma. Well, we have seen that the cumulative incidence of metastasis in 10 years in conjunctival melanoma basically depends upon the thickness of the melanoma, and more than 2 millimeters, it is as high as 30% from this particular paper which was published. So in this prospective study of sentinel lymph node biopsy for conjunctival melanoma, they concluded that any melanoma more than 2 millimeters is good to consider, sentinel lymph node biopsy. Oh, well, PET scan is also there where you can actually evaluate the lymph nodes and other part of the body as far as systemic evaluation is concerned. Now, this is a pigmented lesion of the bulbar conjunctiva. You can see this pigments which is sitting on the iris. Well, is it a conjunctival melanoma? Well, it's something more than that. We can have situation where they can have an intraocular melanoma, which can have extraocular extension. So this is a ciliary body melanoma extending from 2 clock hours to 5 clock hours, and then extending outside the conjunctiva as an extraocular extension of an intraocular melanoma. And these cases can also happen, and we see these cases. Now, going on to a few cases of pediatric conjunctival lesions, it's very rare to find malignant pediatric lesions. This was a child who has undergone conjunctival excision elsewhere. Histopathology was not available. We redid the biopsy, and this came out to be an alveolar rhabdomyosarcoma, which is again a lethal, ocular cancer in pediatric age group. Leukemia can present like conjunctival lesions like this. Liposarcoma can present lesions like this in children. So in children, it is rare, less than 3% of the conjunctival tumors, or it could be an orbital tumor which is extending into the conjunctiva in children, which has to be looked into. Few interesting case here. This is a patient who presented with subconjunctival hemorrhage, where, it's on and off hemorrhage. She's being given lubricating eye drop, but it's more than a hemorrhage. You can see this orangish pinkish lesion over here, which is very, very classical presentation of amyloidosis. So I have a series of amyloidosis. I think we have recently collected 10 cases of ocular adnexal amyloidosis, some presenting as ptosis, some presenting as hemorrhage, some even presenting as extensively like this. This is a large lesion sitting on the bulbar surface, extending into the tarsus. And this was also a conjunctival amyloidosis. And luckily, it was a primary amyloidosis. So this is typical apple green birefringent, which is histopathologically proven for amyloidosis of the ocular adnexal surface. Anything which is, again, red in color, subconjunctival hemorrhage, something you have to keep in mind is Kaposi sarcoma in immunocompromised patients with HIV, and the treatment is antiretroviral therapy. A very, very nice case here where, the patient was treated as chemosis, where she has been hopping from one doctor to another. They all said it's a swelling of the, conjunctiva, probably a chemosis, but it is a very, very transparent, large lesion sitting in the nasal bulbar conjunctiva. Now it's not really new, but well, it was kind of published in the 2000s, late 2000s, where it is called the conjunctival stromal tumor. Another differential diagnosis of this kind of transparent, lesion is myxoma, conjunctival myxoma, where it can have association with cardiac myxoma. So these patient has to undergo echocardiography to rule out any other myxomatous lesion in the body. So with this, I come to the end with very common lesions, very dangerous lesions, how it's so important to diagnose these, some, mysterious lesions, and I hope it was helpful. So we all know that, ocular surface lesions can present in a very, very wide clinical spectrum. It's important to diagnose a benign from an inflammatory to a malignant lesion. And always look for signs of malignancy. If you suspect malignancy, clinically evaluate for lymph node metastasis, do a complete, thorough body evaluation so that a protocol-based management can be planned. And most of the management and the advancement in the management of these ocular surface lesions and cancers has been very, very promising and excellent if it's done appropriately. So thank you so very much for this patient listening. Thank you so much. Did you get bored? Was it too much?
We are so proud. Thank you very much for your talk. Excellent talk.
Okay.
A lot of cases, impressive. I would like to ask you something about the OCT. In which case do you use the OCT for this kind of tumor, or maybe in the neck, in cornea too, in the intraepithelial corneal?
Yeah, that's an excellent question, Dr. Germán. And we often, with the availability of OCT in every clinic now, most of these lesions, especially ocular surface squamous neoplasia, which is involving the cornea, OCT is a must. Ocular surface for documentation about the extent of involvement, OCT is a must. Nevus, conjunctival nevus, in order to confirm, the presence of cyst, microcyst, macrocyst, OCT is always done. And any lesion, if you feel there is some amount of fixity of the sclera, OCT and UBM is definitely done in order to, rule out invasion. Yeah.
Okay, thank you. And also impressive how improved this kind of tumor with the interferon, and it's a really excellent treatment.
Yeah. Yes. Do you get interferon there?
Yes, but we don't have here in the clinic, but yes, it was excellent.
Okay. Yeah.
¿Alguien quiere hacer una pregunta? ¿Prepararon alguna pregunta?
Any questions? I'm here for
Any questions? Okay, no. Well, I would like to invite you for the next, I don't know, the next 2 or 3 months to do another talk about your specialty in retinoblastoma.
Definitely. That's my favorite topic.
Yes, I know, because you have a lot of studies and in many journals about retinoblastoma.
Yeah.
And I think it could be very, very useful for all of us. And I also think that all of these topics that you talked today are very useful for us. And thank you so much for your time. And
Thank you.
Thanks a lot.
Yeah, so in retinoblastoma, we have Dr. Shantada. Shantada is from Argentina. We learn a lot from him. So he's one of the, retinoblastoma super specialist who has contributed a lot in the field. So when we talk about retinoblastoma, Argentina comes in a mind because of Dr. Shantada.
Thank you very much.
Yeah, thank you so
Okay.
much.
Okay.
Thank you so much. Thank you.
Thank you, Dr. Fairooz. You are so
Yeah,
kind.
Dr. Germán,
Yes.
can I say something? So
Yes.
we have the International Society of Ocular Oncology meeting happening in India in December, from December 3rd to December 7th. So it's an international meeting where everyone is coming from different part of the world, and it's purely on ocular oncology. So I extend my sincere and humble invitation to all of you, whoever is interested in ocular oncology, please visit, take part in the conference. And if I am the host, I'm the Congress president. So any help that you need to navigate, to reach, to register, to come, please contact me. Take my, contact from Dr. Germán, and please come.
You.
Yeah.
Thank you very much. I think there is many doctors that after you talk are interested in tumors, in eye tumors. Thank you very much.
Yeah.
Bye.
Bye. Thank you.
Thank you.
Take care. Yeah. Stay warm. Yeah. See you. Bye.
See you. Bye.
Bye-bye.